And our next talk is going to be the surgical options. Dr. Nucci, you can hear us okay?
Yeah, I'm ready.
Perfect, all right.
I'm okay. Just to tell you, to explain you why I am interested in nystagmus now, is because some years ago, when I started to live through my first ophthalmological readings in English, I went over the bibliographies with curiosity and provincialism, looking for some Italian name. And the Italian names were really rare. And for this reason, when I found one, I learned by heart is the name of Luigi Francesco dell'Osso. It is very familiar to me. So I started to study nystagmus, and after a while, I wrote a comment, a kind of editorial for an Italian journal, and I quoted Francesco Luigi dell'Osso, and surprisingly, he wrote me back saying, what you have wrote about nystagmus is completely wrong, so let's sit a little bit and try to understand nystagmus, from a very elementary point of view. So this is my first approach with nystagmus. Now I will share with you my surgical approach, what I usually do with nystagmus, and the second surprise that I read recently, the book by dell'Osso and Hertel, and I found that my approach is quite similar. So I want to share with you the algorithm, the decisional tree that I'm using now. Can I move to the... Okay. Can you see it? Okay. Obviously, we are speaking about infantile nystagmus syndrome, and we have several options in treatment of nystagmus. The first option is to treat the horizontal, typical nystagmus we are used to treat and to approach with the Anderson or the Kestenbaum procedure. The only difference in my way to treat nystagmus now, it's if I choose to do the horizontal, the Anderson procedure, I always put on the tenotomy reattachment procedure described by Hertel dell'Osso. So the approach with horizontal nystagmus is just the same I did a few years ago. The only thing different is when I approach the smallest nystagmus, I do also a tenotomy reattachment procedure. When I treat patients with albinism, for example, they do not have anomalous head posture, what I do is always the same procedure, that is a tenotomy reattachment of the four horizontal muscles. Another approach is to, with nystagmus blockage syndrome, in which we have a strabismus at distance, and what I do is to treat the strabismus with the Parks numbers, but also I used to do the tenotomy reattachment of the other two muscle procedure. This is not what I always do, but this is the approach I'm in the last few years, I would say 2 years, doing with some success. Treating the strabismus with anomalous head posture is something different, and it depends on the... Let me see, go through this. If you are interested in numbers, here are the numbers. I will present you the numbers. With the Anderson procedure, I do the recession of the lateral rectus of 10 millimeters of the AB ducted eye and resection of the medial rectus of 7 millimeters of the AD ducted eyes plus T and R. With the Kestenbaum modified, what I do is the recession of the lateral rectus of 10 millimeters of the AB ducted eye and recession of the medial rectus of 7 millimeters of the AB ducted eye, recession of the medial rectus of 7 millimeters of the AD ducted eye, and recession of the lateral rectus of 9 to 11 AD ducting eye. When we deal with strabismus with the anomalous head posture, A different treatment I do if this was related to a congenital monophthalmos. I don't know if you are familiar with congenital monophthalmos, but was a term used by Annette Spielman, and this is the way that I call the hunter position. So the child with a congenital monophthalmos that sees just with one eye, he uses to have a position of the head like it was a hunter, miring to the object with a good eye. This is always related to the functional maldevelopment nystagmus. In this condition, what I do is to operate just over the fixing eye, and the results are quite good. But if I have also a strabismus related to this, what I do is I straighten the anomalous head position with prism over the fixing eye first. So I use the prism over the fixing eyes, and then I calculate the millimeters. And then, according to this, I do resection with the Parks numbers. After this, I straighten the eyes with the prism over the non-fixing eye, and then using the Parks number, I correct with resection. And I think, Richard, that this is your approach. I think that you mentioned the same approach on your book. Am I correct?
Yes.
Yeah. So the other options is when you have a clear chin-up anomalous head posture. In this condition, I were used to do an inferior rectus recession of about 5 millimeters. But with time, I had a problem with torsion. So at this time, I'm also, according to your suggestion also, doing a tenectomy of 5 millimeters of the superior oblique. And this allowed in 2 patients, I did just 2 patients with this approach, less torsional effect, and this is more, accepted by the patient. In convergent stamping nystagmus, I use the technique to put the prism base out to assess if this is a patient that can have good results with the surgery on the medial rectus. And in this condition, I do always a recession of both medial rectus. These are patient straights for distance of just 3 millimeters of recession associated with tenotomy of both the other muscles. Lastly, in the torsional anomalous head posture, I use what you suggested to detach all the horizontal, all the verticals, to rotate the eyes in the direction of the anomalous head posture, and then reattach them in the operating room, and for one full tendon width to obtain good results. I have not much experience. I just treated 2 patients for torsional anomalous head posture. At this time, I have a series of about 300 patients treated, according to the suggestion by Lou and Rick. And I'm very happy with the results, and I am happy to share the results and to cooperate with someone who has results like this. That's it for my talk.
Did you want to? We have 2 of your videos. Did you want us to play those?
The videos are just, yes, you can put the videos on. This is a...
We'll put it on from here, Paolo.
Oh,
is this one?
they'll take care of it.
Okay, you can do it. This is a patient in which I did a Kestenbaum, a modified procedure. You see the position is...
Paolo,
really
can I interrupt you for a second? I think these videos illustrate a very important point, that there's no eccentric null position that lies completely on the X or Y axis. All of the eccentric gaze null positions are actually in a 3-dimensional space outlined by all 3, X, Y, and Z. This patient illustrates it completely. She does not have a pure horizontal face turn. She actually has a little chin up and left tilt. So if you actually plot the eccentric gaze position in 3-dimensional space, you have to plot it along all 3, a pitch, yaw, and roll axis. Almost every patient has a multiplanar eccentric null position. We always talk about our horizontal Kestenbaum verticals, but no patient does the eccentric null position exist purely along the X, Y, or Z plane. Some of them it's more or less. This patient has a multiplanar null that's largely in the horizontal position. When we make these better and the null zone broadens in all 3 dimensions, then all 3 planes of deviation improve. And I think that clinicians see this, but don't see this. That's been my experience. They look at it, but it doesn't really register as a multiplanar.
I completely agree with you, but we are exploring a field in which we are also a little bit scared of what we are doing. So in a condition like this, you will see the patients, Rick, and you can start with the videos so you see the position before and after surgery.
Right.
What I can tell you is the video. You look at this patient. Obviously, you are right. You are perfectly right, and we discussed this with the parents.
Right.
But the approach is very. I'm very conservative.
Sure.
In this. I'm not going through all these aspects. You see, the patients are very uncomfortable. This was a child seen by other 3 ophthalmologists. No one of them was confident with surgery. So the last one sent him to me, and in this situation, I just said, this is an awful condition. Let me start with a Kestenbaum procedure. And after the procedure, you have seen the movie, the video, and you see this is a normal position. It is awful, absolutely. But after surgery, the position is just acceptable. And I agree with you that maybe doing something more could improve the chin, but this is the results, and this is, astonishing. And the patient and the parents are very happy with this.
Yeah.
So I agree with you that we want to be very picky in this situation. Is certainly important from a scientific point of view, but you have to consider that we have a patient in front of us, and we must be sure that what we are doing is the only possible and true option that we the results of the surgical options. This is a child in which you can start with the video. Is what we call the congenital monophthalmos. She has a microphthalmos in the left eye with a PHPV, I think, in the left eye. So she is used. You see the fusion maldevelopment nystagmus is a latent nystagmus, and the child, to overcome this, used the anomalous head posture. The surgery in this condition was just to recess maximally the medial rectus. After that, she had a mild strabismus, and possibly at this time, I would have operated also on the left eye to obtain an improvement of the results. But you see the nystagmus moved, and the child is straight with the head. So this is the approach with the congenital monophthalmos, in which I see a good result with the head position, just operating over the fixing eye. But I agree with you that in this condition I could do more on the other eye.
Yeah, so this is great, and we have a bunch of questions coming in, and I know, David, you have to go, so I do want to go to the phone. We do have a call-in question from Kathleen. Kathleen, are you there?
Yes.
Thanks for calling in.
There.
Yeah, thanks for calling in. Go ahead with your question.
I understand that the purpose of this conference is looking at the pediatric side of the nystagmus. Is any of this applicable, or any of these treatments or possible treatments applicable for adults who had infantile nystagmus where nothing has been corrected?
Yeah, all of them.
All of them.
All of them.
Yeah.
Okay,
yes.
so
The answer is yes.
It wouldn't hurt to go to try to find somebody who could look at an adult like myself and get some of these measurements and look at these possible treatments.
No, we would encourage you to do that.
Okay, thank you.
Thanks for calling in.
And Rich, it's David. It does bring up the issue of if a child comes in, when is the right time to do the surgery? I'll offer my opinion up, and everybody can throw darts if they like. But I think that there's a component of neural development here that mirrors what we see in critical periods in amblyopia, that you get an advantage by doing this kind of surgery in a younger child. Once you've determined whether or not they truly have an anomalous head position and you're clear that you can get a really good examination, I think it's very reasonable to start proceeding young.
Well, we have data that shows that. We've published it in 2 places, under 8 data and under 2 data, that show that it's a little better. And I'm also going to talk about that in my surgical talk. But the thing that I always say is that if you use the amount of time, this is the strabismus analogy again. If you use the amount of time the patient is posturing, that's really not a great way to determine they need surgery. If the patients could posture all the time, they would posture all the time. The reason they can't posture all the time is because the neck and face and back were not made for them to do that. The fact that they have to posture at all to improve their visual function is clinically very significant. So the idea that somehow they have to posture for 50% of the time or blah, 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 I don't think is that important. I think that the fact that they're posturing at all to improve their visual function, why shouldn't they have that vision all the time? So the adoption of an anomalous head posture, for me, in a child, is a clear indication that they need some type of intervention, medical, optical, or surgical. And the earlier intervention in the neurological system, the better, the more profound the treatment, and that history goes back at least 40 or 50 years to show that. So for my indications, and I hear this and see this all the time. Oh, let's wait till he's 10. Let's wait till he can talk to us. Let's wait till she adopts the head posture more consistently. But I'll show you a little bit something here in my talk that kind of shows you why head posturing is also in the office is not the best way sometimes to guarantee success by looking at head posturing.
All right, and Dr. Mikado had a question about the timing of surgery, and I'm hoping that answered his question. Why don't we move on? You want to move to David's case? Is that
yes?
Or how do you want to do this? What's that?
You know what? I'll do this 5 minutes and then we'll let you go, Dave. Okay? Is that all right?
Oh, sure, no problem.
This just piggybacks Paolo's talk.
Yep, I wanted to ask a question to the panel, or maybe you'll cover it when you talk, is that there's another approach to a head position that's not the Anderson-Kestenbaum or the Parks number, and that's viewing each eye as an EZO or an XO eye and correcting it with our typical R&R numbers, which we're more comfortable with. And I just wanted to throw that out there as you discuss the approach to the head turn, that there is an alternative way. And also in my talk, I want to raise multiplanar surgery, and I know you'll be talking about that as well, so maybe we can tie it all together.
Okay. So I'm going to talk a little bit about surgery, and actually it really dovetails very well with Paolo's.